Hello everybody, it is Wednesday, December 29. Surprise, surprise, I know in our last video we signed off for 2021, but it is not 2022. We're back again. Quite honestly, there's so many variables in the air, and as you all know, Gary and I thought it'd be important to touch bases, and we're going to try to educate you a little bit today. It's going to be a longer video, I'll tell you that up front, because there is so much going on. We will send all the slides out afterwards, so you don't have to memorize what we're telling you. So I'm going to jump right in and talk about the epidemiology again. You've certainly been reading in the paper about what's happening in New England and now in the Midwest, and we're starting to see this migration of COVID come across the United States. So our first slide here looks at the state of California, and this is isolates out number of cases, and so you can see the new cases and 7-day average in the state of California starting to spike up. It's a little bit higher than our last peak in the fall. The next slide looks at the Sutter Health data. So this is Sutter Health Lab, just in the Bay Area, then it's a representation. And this is different. This is looking at number of cases and percent positive of cases. So you can see just in the last week, we've seen a big jump in the positivity. It's running right now about 15.9, I believe, percent positive cases at Sutter Health for symptomatic patients. So that's a dramatic change. And then the last slide is narrowing it down to Sonoma County, where, as we pointed out before, we're pretty heavily vaccinated. But we are starting to inch up now. You'll see this is again back to looking at cases, not percent positivity. So slowly inching up, not to where we were in the fall. So generally what we're seeing is that COVID has come across the United States, and in the state of California, really started in LA, and it's coming north now. We're starting to seeing it in Sonoma County. So these are positive, percent positive tests. These are cases. What are you seeing in the hospital, Gary?
So the ER is pretty busy with a number of outpatient diseases, but we're not admitting that many patients. Okay. Really only a handful of cases in the hospital, and all of the hospital cases are unvaccinated. So predominantly 99% of what we're seeing in the hospital, when someone gets hospitalized because of hypoxia and pneumonia, is going to be in the hospitalized patients.
Okay. All right, so let's move on and touch base and catch up with where we're at with the variants.
Yeah, so I think it is important for people to know we are going to show a lot of slides today. It's going to feel like grand rounds, but we'll go through the slides carefully, and we want to kind of add some visual effects so that it helps sort of understanding and gaining perspective. The first thing I want to talk about is how we track the variants. There's been a lot of information about the Omicron tracking in California, 50 to 70% positivity rates. I didn't find that. So the first slide I'm going to show you comes from Sonoma County Public Health. This is exactly their data, and I pulled this off last night. Their data is up to December 21st. That's a little bit late for COVID, right? Right now, week to week, that's a little bit old data, but a week ago, Delta was 93% of their cases, and the Omicron was 6.5%. That might be double now. Maybe that's 13, maybe that's 50% now. I don't see the 70% numbers right now. But if you look down at the lower part of this slide, then this is the USA data, and the United States data shows that, and this goes week by week by week. You can see from November to December here, and as of December 25th, Omicron was 58% of the cases, and Delta was 41%. So you can see that the Omicron is becoming more prevalent in the community. It clearly is more infectious, which also means that it's going to have probably more viral fitness, and it's going to become the predominant strain.
So this kind of supports the fact that we haven't seen a big surge in Sonoma County yet, because we haven't seen a big surge in Omicron yet.
That's correct. Yeah, I think we're and like you said before, Gary, we're more than 80% vaccinated in this county. I think we're very well positioned. My gut feeling is we're probably going to see an Omicron wave, but we're probably not going to see a surge.
Yes.
Now, I got this question, and I'm going to just shout out to Sally. Sally's great. She always gives me just very fundamental and practical questions. And she's like, what's the chance and what's the data for breakthrough infections with Omicron? And really, Sally, we don't have that data yet. We're really watching what's happening in South Africa, but South Africa is not very well vaccinated compared to the US, especially Sonoma County. What we do know in the pre-Omicron period, mainly the Delta strain from January to December, this is US data, that 1.37% of the test positive were in people who were fully vaccinated. So that's a pretty low number. Less than 2% were fully vaccinated. 98+% were unvaccinated folks. But if you did test positive, if you were vaccinated, the hospitalization rate for fully vaccinated was 0.05%. That's super low. And the chance of having a fatal illness for being fully vaccinated, that data was 0.01%. And that was mainly in the elderly. So those over the age of 80, those are immunosuppressed, the really frail, medically frail patients are the ones that don't survive COVID even though they are vaccinated. But again, the Omicron data, we just don't have that right now. We know there's going to be a few more breakthrough infections with the Omicron. We clearly see that, and that's because vaccine efficacy has gone from 95%, it dropped to like 50, 60%, 40% range in some areas, but now with the booster it's 75%. So with the booster, your vaccination protection is back up to 75%. We're going to see some breakthrough infections, and they're very likely going to be asymptomatic or mild.
And that was the data we showed 2 weeks ago.
That's correct.
The UK study that showed with the booster you can really regain much of your protection.
That's right, yeah, with the Pfizer booster, which we also equivalent probably to the Moderna booster as well. We'll see that, but it's not going to get up back to 95%.
So we've heard a lot about everybody talks about how contagious Omicron is. So now you've got some data to talk about to picture that for us.
Well, I wanted to give people perspective, and I want to go back to what we know. The science about pandemics has always been with what's called the basic reproductive number, and we have that number for a lot of things. I want to make a couple statements. One, the basic reproductive number is called R0, or R little zero. And the R0 number represents how contagious something is, but it's not a constant number. It's a dynamic number. In other words, if the R0 number is let's say 2 in a vulnerable population, if you change strategies, you could lower the R0 number. So it's a number that we can work with. Now, we know the R0 number for a lot of things, and I'll show you the first slide. To the left-hand side, the R0 number for tuberculosis, 0.55 in the US, which is why we don't have a tuberculosis epidemic. The R0 number for seasonal flu is about 1.2. And I'll tell you what that means in a few minutes. The R0 number for the 1918 pandemic flu, which was very severe and very virulent, was really 1.5 to about 2.5. Ebola virus, everyone asks about that, about 2. So the first SARS coronavirus in 2003 had an R0 number of 2 to 5. And so it kind of depends on how close quarter people were. Mumps is about 7, chickenpox is about 10. R0 number for pertussis and measles, 12 to 17, 12 to 18. And measles clearly is one of the more contagious things. So how does the variant stand up against that? The original COVID, this is to the right now, the original coronavirus from China probably had an R0 number of 1.5 to 3. And then when the first variant came out, and it was discovered in a number of places, but especially in Italy, they had a huge wave of infection, but the R0 number didn't really change. It was still in the mid-2s, and probably Italy got hit in the northern part because of their really cohort and their crowding of elderly patients. When the Alpha variant was discovered in the UK, that R0 number went up to 4. Now when the Alpha variant came out, it became more contagious and it became more severe, so 30% more severe. When the Delta strain came out of South Africa, its R0 number bumped up above 5. And as you can see, the virus is becoming more contagious, and the Delta strain clearly has become more virulent, even in younger populations. Now the Omicron probably has an R0 number over 7. So it's clearly more contagious, 30% more contagious than the Delta strain. But for the first time in the pandemic, we have a variant that's come out that is now less severe. And I think we've really turned an evolutionary corner there. Now we have something that is more contagious, but less severe, and we're going to see this become now more endemic. And I think evolutionarily this pandemic has turned the corner. Very similar to 1918. After a year, after the first 3 waves, in the second year, the H1N1 flu became more endemic. And that's what we're seeing right now. So the natural evolution of this virus has now become less virulent, but more contagious. The more contagiousness means it's going to outpace the Delta strain. So there are 2 reasons why the Omicron strain is going to be more prevalent than the Delta strain. 1, it replicates faster, and 2, the few breakthrough infections in vaccinated people means it has a larger host of patients to circulate in. And so I think that's why it's going to be much more prevalent and predominant. But let's break this down. So those are kind of the numbers. But But I kind of want to walk you through something, and this is where it's kind of more of a grand rounds. Just to remind you kind of what that R0 number is. If you have an R0 number of 2, like let's say this is a bad seasonal influenza year, an R0 number of 2 is the red dot. And this person is going to be going into a very vulnerable population, and those are the white dots. The white dot represents people who are not vaccinated, they're vulnerable, they're not wearing masks, and if your R0 number is 2 in a vulnerable population, what's going to happen is, after the arrow there, is you're going to have 2 more people infected in that cohort. And then with one more cycle of cases, that 2, each of those patients infects 2 more people, that goes to 6, and it becomes exponential. So it's not a linear escalation of cases, it's a logarithmic one. And that's why you have this explosion of cases during the flu season when we see it go through a nursing home, for example. So now, what if we have an R0 number 7? So that's where the Omicron is right now. If you have an R0 number 7, and you go into a vulnerable population, again, unvaccinated population, that 1 case leads to 7 cases. And then with the second wave, 49 cases. So you can see how when the R0 number goes up, when you develop a more contagious illness or a more contagious virus, that you get a higher explosion of cases. And that becomes really, really difficult. So let's kind of pause that for a minute. So right now, you have this R0 of 7, and if you look at one more slide in the lower part, is you'll see that what if that's not an unvaccinated population, but a vaccinated population? And so the blue dots represent the vaccinated folks. And the white ones are people who chose not to be vaccinated. And this kind of represents Sonoma County. So if you have this vaccinated population, now it's harder for that person to develop, to spread the infection in that population. And so if you look to the far right, if you do have transmission, maybe 1 person becomes infected. And then I put there a little blue gold dot. Maybe that's a breakthrough infection. So maybe you have 1 breakthrough viral infection in that cohort. So even though you have an R0 number of 7, you've changed that R0 number 2 because of vaccination strategies and social distancing. Now, let's take that one more level. One more level is going to be, what if you put a mask on everyone? If you put a mask on everyone with an R0 of 7, on the top you're going to see fewer cases, but still some people who are wearing a mask still get infected. But if you have a vaccinated population and you wear a mask on top of that, now you really drop the R0 number even lower. And so that's what we mean early on, in the very early part of this pandemic, of flattening the curve. We wanted to flatten the curve by changing the R0 number so that the vulnerable population was not as exposed. And you can do that with vaccine, social distancing, wearing a mask, and keeping your bubble small. All those things really make a big difference. But the most important thing to change your R0 number for every disease throughout history has been vaccination.
So those are the variables under our control.
Right, so from smallpox to pertussis to measles and now to COVID, to SARS-CoV-2, vaccination is clearly going to be the biggest strategy. Now we'll talk about vaccines in a minute because we have the best vaccines in the world, the Pfizer and Moderna vaccine, and the other vaccines, J&J, AstraZeneca, as well as the vaccines in China, and the vaccines in Russia, they're just not holding up. And some of them have 0 activity against the Omicron strain. So in the US, getting vaccinated is still really going to be the most important thing we do.
Good. All this indicates back to the basic message we've been given for about 20 months.
Right.
Same message, basic variables under our control. All right.
Yeah, it's sort of a different way of understanding it.
Yeah.
And even though when you walk down different scientific methodologies, you come to the same answer, which I think really represents wisdom.
Let's talk about treatment then. So we still have 2 modalities of treatment essentially, monoclonal antibodies, and now the newest thing, these orals that have been recently approved for emergency use.
So we break down treatment into 2 categories, ambulatory side and the hospital side. So in the ambulatory side, we have a number of effective things like controlling diabetes has been helpful to survival, but new on the scene has been monoclonal antibodies, a couple new ones. And the information to update you here is that there's a new monoclonal antibody approved by the FDA under EUA, emergency use, called I have to kind of pronounce this, Sotrovimab. And it's approved for people who are 12 years of older, and it's effective against the Omicron strain. and that's what's more important. I put a couple things here, and in the in italics there, the other monoclonal antibodies, including Regeneron, are now ineffective. So all other monoclonal antibodies are not working for the Omicron strain for treatment.
So
So the only one, right? There's one antibody, one monoclonal antibody to know. We're still struggling with acquiring it and knowing where to give it. And so we're securing it from the health department. And so Carol and Dan's been helpful to try and get a shipment of that to our ER to treat people in that setting. And then Evusheld is actually a dual monoclonal antibody. Evusheld is a new on the scene, FDA approved, but it's not approved for treatment. It's only approved for post-exposure prophylaxis. And that's very important to know. So it's really targeted for the immunosuppressed or people who for allergic reasons couldn't get vaccinated. But it's really earmarked for people who are severely immunosuppressed, who have no other protection, they're not responding to vaccine. This is the advanced immunosuppression of maybe myelosuppressive chemotherapy or advanced immunosuppression of kidney or other transplantation.
So what I hear you saying is this to be used for people that we hear from a patient who's been exposed, so we say, oh, they're a high-risk patient, or are you saying it's people who've previously been identified as having a failure of immune response and so forth, that they're the only ones? Because I don't know how available this will be. It's likely to be in.
Right, so this is post-exposure prophylaxis.
Yeah.
I've been exposed, I'm really immune suppressed, and usually that's more of a household exposure.
Okay.
I've been exposed in the house, I'm very immunosuppressed, and probably what's going to happen is their provider is going to say, we need to do something here. Their oncologist, their transplant doctor, their immunologist.
So it's likely going to fall in that realm as opposed to the average patient that we see in, say, Medicare and primary care. It's going to be the people who've been identified by oncology and so forth, because I'd imagine it's going to be a very short supply.
Right, it is a short supply, and it's not earmarked for people who say, I don't want to be vaccinated, but give me monoclonal antibodies so I can be protected. Okay. That's not really the indication here, because then we'll use that for a cohort of patients that would respond to vaccine and not have it for those who are.
And do we know if we have this at all in the hospital?
I haven't used any of it yet,
okay.
So yeah, it's an incredible sparse supply.
Yeah, okay.
So that's monoclonal antibody update. And on the antivirals, we have 2 antivirals that are now EUA approved by the FDA. Paxlovid is the protease inhibitor. It's actually 2 drugs because it's boosted with ritonavir. So people who are used to doing HIV treatment know that we boosted the protease inhibitors with HIV with ritonavir all the time. And if you have experience with ritonavir, you'll realize that it has it's a very potent inducer, hepatic inducer of the 3A4 P450 pathway. And so because it induces metabolism, it drops the drug level of a number of drugs. And I put the drug interactions here. So people who are used to using ritonavir realize that ritonavir has a lot of drug interactions, and you want to be very careful with it. That being said, the CDC has stated this is probably the preferred treatment, the preferred monoclonal antibody, because it has an 89% reduced risk of hospitalization and death. So it's effective when you use it within 5 days. It's approved for 12 years and older. It's going to be hard to find it, and I'm going to show you some slides on what we know about how it's going to be distributed. But I want to just put a caution out there: be careful of the ritonavir component in that. And then molnupiravir is the Merck drug that's also approved for 5 days, within 5 days of symptoms. It's approved 18 years of age and older. And it has a 30% relative risk reduction in hospitalization and death. The new thing about molnupiravir is that in animal studies, it might be mutagenic. And so it's very important that it could potentially cause fetal harm, and it could also affect sperm. So you want to counsel patients using that to be very careful not to get pregnant. And if you are pregnant, it's going to be a risk-benefit ratio if you can't receive other treatments. So there's an element there to the mutagenic potential of molnupiravir. Now, the FDA has designated CVS to be the pharmacy to distribute those. So the federal government is actually providing these medications based on on incidence and case prevalence to different pharmacies. So what's interesting about that, and I'll show you in a couple slides, is we got a fax in our office from CVS, and I boiled that down for everyone. But probably a really important slide for the docs is, well, what are the indications? When do I use monoclonal antibody? So actually Gary McLeod just found this. This is actually the package insert coming out from the FDA. So the package insert for Paxlovid is treatment of mild to moderate COVID at risk for progression to severe COVID, including hospitalization and death. So who's at risk? And what they do is the eligible subjects have at least one of the following risk factors: age over 60, diabetic, obese with a BMI over 25, chronic lung disease that includes asthma, chronic kidney disease, but it wasn't stated at what creatinine clearance, current smoker, so current not previous, immunosuppressant disease or immunosuppressant treatment, and they don't specify, for example, what dose of prednisone, what dose of methotrexate, and that. Cardiovascular disease, hypertension, sickle cell disease, neurodevelopmental disorders, active cancer, and then this medically related technological dependence. I have no idea what that last one is. I really don't.
So watch out for it.
But that is right from, I mean, is that a pacemaker? I don't know. So, but that's right from the package insert. So these are the indications, and when we send these slides to you, you can sort of print that.
Yeah, so I would point out that is extremely broad. So
Yeah.
BMI over 25.
Well, age over 60.
Age over 60,
Yeah.
and BMI at 25 is a huge population. So I would imagine this would be very difficult to get this drug. But we'll see what kind of supply CVS gets.
Right, it's going to be supply and demand, right? There's going to be this enormous demand. And this is treatment, not post-exposure, right?
Yeah.
So this is going to be tremendous. Imagine all the nursing home patients who would qualify
Yeah.
for this.
So
if
where are we
there's an
gonna get
outbreak. So CVS sent this email out. This is the next slide I'm going to show you, is that CVS sent this out. This is right from that fax we got to our office. And it was 9 pages long. So I pulled out what's local to us. And I highlighted here, there's only one CVS pharmacy in Santa Rosa that's going to have it, and it's going to be at Stony Point Road. And the phone numbers here, so you or your patients or your staff can call and see, do they even have drug there?
Yeah.
And then the other ones are, there's going to be one in Napa, one in Lakeport, one in Fort Bragg. There's going to be one in Berkeley. There's going to be 7 CVS pharmacists in San Francisco. But the federal government has earmarked CVS Pharmacy to be the distributor of oral drugs, and we expect there's going to be a huge demand for these, and probably they're going to run out pretty quick.
Yeah. So Gary, one more thing we want to point out that has been a change. There's been a lot of this, and actually the media, the press, and the news is about the CDC changing their guidelines for quarantine and isolation. I have to admit, I never really thought about this. Quarantine is for people who are exposed, and isolation is for people who are sick.
That's right.
Who are infected.
That's a really important, important. We in the hospital, it's very important. We actually follow the same thing. And you're right. If you're infected, you're isolated.
Yeah.
If you're exposed, but you're not symptomatic, then you're quarantined.
So these are the new guidelines. Do you want to go over these?
Yeah, so this is going to be great for the docs. This is something I would print out, just put in your office. So this is updated as of December 27th. And the current understanding, and this is based on our current understanding of not just COVID-19, but of the Omicron variant. So this is even with a more contagious variant. The CDC has changed that if you're asymptomatic, but you test positive, so let's say you're testing positive for travel, or you're going to have a procedure, for example, and you test positive, but you're asymptomatic, the quarantine period has changed from 10 days to 5 days. So that's good. So now you only quarantine for 5 days if you test positive, but you're asymptomatic. But then for an additional 5 days, you need to really be strict about wearing a mask. Now, if you're symptomatic, it's an outpatient, and you test positive for COVID, hasn't changed at all. That is an isolation time, and the isolation period there is for 10 days. But what about people who are exposed? If you're exposed to a confirmed COVID case, but you're asymptomatic, if you're unvaccinated, if it's been more than 6 months from your second dose of Pfizer or Moderna, or you're more than 2 months from the J&J vaccine and you're not yet boosted, again, the quarantine there is 5 days. So 5 days for exposed and asymptomatic, and strict mask for an additional 5 days after that. If you're boosted, if you've been boosted and you're exposed, but you're asymptomatic, no quarantine is needed. And the CDC recommends, they say consider testing at 5 days after exposure, but it's not mandated to do so. So this is for the general population. I kind of boil this down as simple as I could. This is something you might want to just print out, put next to your desk, so that if patients call and you have questions, you can refer back to this. And this is directly from the CDC website.
Okay. Then the other thing we need to point out is the CDC has also put out a change in their recommendation for healthcare workers. You might have read about that. But I will say that we have not made any changes in our recommendations for isolation and quarantine for healthcare workers. And that is just because the state of California has not blessed that, and Sonoma County has not blessed that, and Sutter Health has not blessed that yet. So I think, Gary, you told me that the chain reaction is California has to say, we endorse the CDC guidelines, and then Sutter Health will address it, and they will indeed come out with a recommendation.
Yeah, that's right. The Sutter system is waiting for the California Department of Health to issue what's called an all facilities letter, an AFL letter. So when CDPH endorses and delineates exactly what the healthcare worker isolation, quarantine guidelines are going to be, then we'll follow that.
Okay, so that'll be coming. So hold off in the terms of how we treat ourselves. Other things that are coming is there will likely be changes in the PPE recommendation, and this is in a state of flux. It could be any day that will change. What you can anticipate is at its extreme, we may be asked to don N95s and goggles, perhaps for all patient encounters. So sit tight, continue to do what you're doing now, but that recommendation may be coming soon. The other thing I want to point out is this is specifically for SMGR clinicians. Testing for SMGR clinicians, nothing has changed. So if you are ill and you want to determine if it is COVID, then please just call the same-day care, call their front line. You do not need to call Sean, you do not need to call the manager, the back line. Just call the front line, say I'm a SMGR clinician, I'm ill, I need to be tested. So the only question they're going to ask is, do you need to see a provider? Do you need to be evaluated? Are you that sick? Or do you just need to be tested? So that process is still in place, so I'll remind you of that. We are not testing asymptomatic people right now. So if you have an exposure, we are not running those through same-day care because we just have this valuable commodity of testing that we want to hold on to. And then the last thing I want to point out is a new state mandate for boosters. So as of February 1, 2022, California State is requiring all healthcare workers to be boosted. So you've got about a month, if you haven't done that already, to get boosted. If the information we presented already isn't enough information to show you that's the only way you're going to regain your previous protection. So I would encourage you to do that. For those of you who got boosters outside of Sutter Health, let's say at a pharmacy like I did, we're going to need you to upload that information into the Sutter system so it's trackable. Sit tight right now. Within the next 24 to 48 hours, we're going to send you information of how to do that in a quick fashion. So that's coming. Okay. So a lot of information, a lot of heavy information. Next time we talk to you, things will be different, things will be changing. So let's just finish it up on this slide. This cartoon, basically, this is a long, hard slog, and there is no easy way around this, and we'll do what we need to do as we have done in the past. So hang in there, everybody, and keep safe. Happy New Year for both of us.
Thanks.